Thanks for joining me in the AmSECT flipped classroom. This is the preparatory module for the talk that is titled Coagulation Metrics and Blood Product Recommendations, which will be facilitated by Jeff Riley and myself. I am Bruce Searles from the SUNY Upstate Medical University, and today we're going to talk about coagulation monitoring, and we're just going to provide a quick review for the cardiovascular perfusion professional. The objectives for this talk include a 10,000-foot view of coagulation and anticoagulation. We're looking at a very broad perspective. We're not going to look at all the minuscule detail as if you were a hematologist or a biochemist. We're just going to focus on coag as it applies to our decisions and actions in cardiac surgery. We'll also look at the common tests and parameters that are used to make decisions about our bleeding patients. And we'll discuss the blood products that we can use to treat these coagulation problems. The goal for this screencast is to set the stage for a more engaging and thought-provoking face-to-face presentation when we get together in Baltimore. So let's get started with this review. We're going to look at coagulation and anticoagulation, the tests you can use to monitor coagulation, and the products that we can use to treat coagulation. Hopefully with this background, we'll be prepared to discuss and troubleshoot some scenarios. First, of course, I need to point out that I mean no disrespect to the hematology buffs in the audience. Those of you that are really passionate about coagulation, and you know who you are. This coag summary is not a study of biochemistry, but rather the brass tacks, the bottom line, the bare bones of coagulation. Just what we need to know to address the majority of our patients' bleeding problems. So here it is. Bottom line is, coagulation can be boiled down to only two components, the cells and the protein. The cells are the platelets. Proteins represent the entire clotting cascade. So from here, let's go ahead and sketch that out, and I'll show you what I mean. Now I recognize that it may have been 2, 10, even 30 years since the last time you drew the coagulation cascade. So this little review may be timely and appropriate, but I also recognize that you've all done this before. But we're not going to, as I said, get into the nitty-gritty detail too much, because this is coagulation simplified. Let's start here with the initiation of a clot. Tissue injury or the contact of blood with foreign surface generally initiates coagulation. And the goal of coagulation is to get the platelets to interact with proteins so that we can form a nice solid clot and maintain hemostasis. The end product of the coagulation cascade is a protein called fibrin, which is formed from fibrinogen. Classically, the coagulation cascade that produces fibrin is represented as having two separate pathways which can initiate the common cascade pathway, the end of which is the production of fibrin. One of those initiating pathways is called the Intrinsic Cascade. The Intrinsic Cascade is initiated by contact with foreign surface, and of the two initiating cascades, it is slower, taking 2 to 6 minutes in vivo to be completed. The lab test that we can use to monitor the intrinsic cascade is the PTT, or the partial thromboplastin time, and that test runs about 35 seconds and evaluates all of the coagulation proteins from 12 down through the common cascade until you reach fibrin. The other initiating cascade is called the Extrinsic Cascade. It's initiated by tissue factor, and it is much faster. It's only one plasma protein long, factor 7, and it can be monitored with a lab test called the PT, or the prothrombin time, which lasts about 11 to 15 seconds. That PT test evaluates the entire extrinsic cascade from 7 on down to 1. And while this is the classical representation of the coagulation cascade, we understand now that this is not really how clotting occurs in vivo. For instance, we understand that there's a lot of crosstalk between these branches, including factor 7 stimulating factor 9, and factor 2 providing a positive amplification system up to both the intrinsic and the extrinsic cascades so that the whole process runs faster. Now you might ask that if we know that clot does not occur this way in the body, why do we bother to still teach it this way? And there's a good answer for that. The answer is that this model was designed based on our understanding of these tests, the PT and the PTT. And given that these tests are still used clinically, this coagulation model helps us understand the results of those clinical tests. But given that most of our patients that we see as cardiovascular perfusionists have developed their coagulation issue as a result of the care they're receiving, we generally don't have to concern ourselves with all of the fine detail of these protein interactions. In fact, for our purposes, it's generally okay to simply understand that everything above this red line represents plasma proteins. And these plasma proteins interact with each other to produce fibrin monomers that then form a mesh on the platelets, are reinforced with factor 13 to ultimately produce a clot. The clot is a whole blood phenomenon, and we can monitor clot with a test that we are all very familiar with called the ACT, or activated clotting time. Now that test has its own limitations. It has limited sensitivity to platelets. Oftentimes the ACT test will tell you that a clot has formed, even if you have very poor platelet function. Additionally, ACTs stop at the formation of a clot, so no information is provided about the long-term life of that clot. These limitations can be overcome with thromboelastography, and there are several machines that will provide that. And these machines give you data about the kinetics of that clot, which is a manner of measuring the independent contribution of the clotting factors and the platelets to the formation of a whole blood clot. Additionally, thromboelastographs provide information about the breakdown of clot, giving us metrics of fibrinolysis. So while a great deal of study can be dedicated to all of the complex interactions that go on in the formation of fibrin and fibrin's interaction with platelets, there is, from a clinical perspective, a very simple formula for coagulation, and that is that clot equals proteins plus platelets. The platelet variable of this formula is easy to understand because that is a product you can order from the blood bank. The protein portion often, I believe, gets mired down in all the complexity of the coagulation cascade, and it's rarely been helpful for me to be at the patient's bedside thinking 12, 11, 9, 8, blah, blah, blah. So from a clinical perspective, when trying to decide on the proper therapy for our bleeding patients, the protein factors can simply be summarized as plasma, and there are several plasma products that can be ordered from the blood bank. And so with that, we have wrapped up our introduction to clinical coagulation for the heart surgery patient, establishing that there's two functional elements necessary for clot, those being platelets and clotting factors. And we can continue on to take a look at the next subject of anticoagulation. We're going to look at several variables that may inhibit coagulation for our patients, and by design, heparin is the most common explanation for an inhibited coagulation system in our patients. We give large boluses of heparin to our patients for the express purpose of causing anticoagulation. Heparin inhibits both the platelets and the proteins. Its effect on the proteins is mediated by antithrombin 3, which is a normal plasma protein that is very effective as an anticoagulant. Its job is to slow down the protein cascade that leads to fibrin formation. But the presence of heparin superactivates AT3 more than 1,000 times. While the interaction between heparin and AT3 has been known for a very long time, it seems that AT3 became a common word in our profession sometime in the 1990s, when the first reports of our heparin resistant patients were being discussed. This reported phenomenon of patients who are resistant to the anticoagulant effects of heparin was quickly explained as a deficiency of antithrombin 3 and associated with prolonged heparin administration. So nowadays we understand that heparin resistance is really a misnomer, and the more correct term should be antithrombin 3 deficiency. Another variable that is quite pertinent to our patients is hypothermia. Both the coagulation cascade and the platelet activation require multi-step biochemical cascades of protein interactions. This biochemistry is designed to run at 37 degrees and is very sensitive to even a few degrees of temperature change. So it should be obvious that we should make sure our patients are warmed back up to 37 if we need the coagulation system to function properly. Now, that said, it may be worth pointing out that the tests we run at the bedside and in the lab warm the samples up to 37. A hypothermic patient may have difficulty forming a clot, but the lab tests will all be normal since the tests are run at 37. You actually have to look out at the monitors and determine that your patient is warm to help you interpret the results of your tests. Bleeding associated with platelet problems comes in two categories: insufficient platelet count and insufficient platelet activity. It's pretty easy to understand that if you don't have enough platelets, you won't get the desired effect. So activity is the trickier of the two. About a decade and a half ago, stimulated by the cardiologist's widespread adoption of platelet-inhibiting drugs for the patients in the cath lab, many perfusionists started to become experts in platelet activation, learning the names of all the receptors and the drugs that can inhibit them. But we have already stated that heparin is a significant platelet inhibitor. Additionally, patients may be taking meds or vitamins at home that are inhibiting their platelets. Given that there are so many agents that can inhibit our patients' platelets, and they are on board before the patient even comes to the operating room, it may be prudent to recommend preoperative platelet function testing. Bleeding associated with insufficient coagulation proteins, clotting factors, all fall into two categories: dilution and consumption. There are some good papers that establish that you need more than a 50% reduction. Actually, it's more like a 75% reduction in your factor concentration before it inhibits your ability to form a clot. But that degree of extreme dilution is not impossible for our patients. For instance, very small patients placed on relatively large bypass circuits, or perhaps patients may have received large volumes of crystalloids from anesthesia, or consider the patient with a lot of intraoperative bleeding who over the course of their surgery has their entire blood volume spun through the cell saver. There are a number of ways that our patients may become grossly diluted. Consumption, on the other hand, is not about misplacing the patient's clotting proteins. It is a result of the patient using their clotting proteins ineffectively, perhaps throughout the surgery due to inadequate anticoagulation, or perhaps after the bypass run in an attempt to form a clot against the odds of inadequate platelet contribution or inadequate surgical hemostasis. For our long-term ECMO cases, it is not uncommon for the patient to develop factor deficiency associated with disseminated intravascular coagulation, or DIC, as a result of the prolonged contact with foreign surface and progressively larger stimulating clot loads within the circuit. While these patients are actively consuming the coagulation proteins to convert fibrinogen to fibrin, they are also actively breaking down the fibrin strands. This process will continue until the stimulating element is removed or they run out of clotting factors. This may be diagnosed by monitoring their fibrinogen concentration as well as byproducts of clot formation and dissolution, for example, your FSP and your D-dimer variables. So in summary, there are many reasons for our patients to remain anticoagulated after weaning from bypass. So now, let's take a look at the tests that we use to figure out why the patients are bleeding. There is a limited battery of tests that we can run to help focus in on the cause of the patient's bleeding problem. And the source of the bleeding is inevitably one or a combination of these things. Either it's our fault because the patient is still heparinized, or perhaps they are undergoing a heparin rebound effect, which is when heparin that has migrated out of the vascular space or been bound to intravascular proteins begins leaching back into the bloodstream and reheparinizing the patient after a previously successful reversal with protamine. Or perhaps there's a functional deficiency of the platelets or the clotting proteins, which may be specifically insufficient fibrinogen function or a more global factor deficiency. For each of these elements, there are laboratory tests and there are point-of-care tests. The anti-10A test has been getting a lot of attention lately, particularly in the ECMO arena. This laboratory test determines heparin level and has been shown to provide results that are similar to protamine titration tests. In the operating room, even if we don't use these tests in our practice, most of us are at least familiar with the heparin level assays that are available from the Medtronic HMS system and the heparinase tests that are available for several different manufacturers' ACT tests. To review, the heparin level assay employs a protamine titration to determine the concentration of heparin in a sample. And the heparinase test employs an enzyme to cleave and thereby deactivate any heparin that is in the sample. Between these two tests, the heparinase tests are less sophisticated in that they will only tell you that there is or is not heparin in the blood sample, while the heparin level assay will quantify the amount of heparin that is in the sample, and the device can then even make a recommendation as to the proper amount of the protamine to reverse the remaining heparin. If you don't have these tests, then probably in the past you have given a patient an additional 25 to 50 milligrams of protamine to empirically rule out residual heparin as the source of bleeding. This is fine, but you must be cautious to not overdo it, since protamine has its own anticoagulatory effects, and this can make your patient's problems even more complicated if it is given when it is not indicated. To evaluate the contribution of the platelet in hemostasis, we can send blood to the lab for platelet count, or request a platelet activity or a platelet function analysis test. The normal platelet count is 150 to 400,000 platelets per microliter, and if the platelets are working well, hemostasis is often possible in thrombocytopenic patients down to as low as 30,000. When the platelets are not working well, however, hemostasis may be attenuated even with normal platelet counts. So practically, it's more valuable to get a test of platelets function versus the platelet count. In the lab, these tests take hours to perform, so point-of-care tests are an attractive alternative. Thromboelastography can be performed by 3 different point-of-care devices: the TEG, the Rotem, and Sonoclot. A comparison of these machines is beyond the scope of this presentation, but we will discuss the results of the TEG as we continue on through. This is a graphic representation of a TEG tracing, which includes the test results like R and alpha angle and MA and LY30, but it also has the blood product that you would use to treat each individual test result. In this case, the last thing we talked about was platelets, and you can see that if you're reading a TEG trace, the platelets function are recorded in the MA variable. To evaluate the contribution of fibrinogen to hemostasis, the lab can provide a fibrinogen concentration. You may also note that your ACT is running a little long, or that the K and alpha angle on the TEG have decreased. Let's identify those variables on the TEG tracing. Right here, at the upswing and downswing, when the straight line bifurcates, that's the alpha angle, and it represents the fibrinogen 80% fibrinogen. As we saw in the illustration we drew earlier, the PT and the PT tests monitor the function of the extrinsic and intrinsic clotting cascades respectively. In fact, the very concept of the extrinsic and intrinsic cascade is based on these tests. With your point-of-care devices, you may notice that your patients with clotting factor deficiencies have prolonged ACTs, and on the TEG, you will have a lengthened R time. On that TEG tracing again, R represents the liquid phase of the blood right here. And as that gets longer, then it is indicative of a shortage of Coag factors. So to summarize this section of the presentation, we have monitoring tests that can be performed in the lab or at the bedside for residual heparin, platelet function, fibrinogen function, and overall Coag factor performance. Let's move on to our next subject, which will address the therapeutic treatments for patients with coagulation deficits. While there are a few pharmacologic approaches to the bleeding patient, this presentation focuses mainly on blood products. Therefore, a brief review of how these blood products are produced may be in order. Whole blood is collected from donors and preserved with ACD, which is an anticoagulant that binds the ionized calcium. That whole blood product is spun to separate the packed red blood cells and other red blood cell products from the plasma, which at this point is called platelet-rich plasma because there are still platelets in it. That platelet-rich plasma can then be spun to separate the platelet product from the platelet-poor plasma. The platelet-poor plasma, if it is frozen within 8 hours, will be called fresh frozen plasma, but if they don't freeze it for 24 hours, then it may just be referred to as fresh plasma, or FP24. When that fresh frozen plasma is thawed, then a protein precipitates out of the solution, and that is called cryoprecipitate. And the remaining solution is a factor-deficient plasma. Only about 10 to 15 milliliters of cryoprecipitate can be produced from a single donor's fresh frozen plasma, so it is usually pooled. That pooled product of cryo has significant concentrations of fibrinogen, factor 8, von Willebrand factor, and factor 13. So let's start putting some of this to application. If our patient is bleeding and the ACT and the PT and PTT and the R times on the TAG are prolonged, but the fibrinogen concentration is normal, and we have ruled out residual anticoagulants, then we can conclude that the patient needs factors and should be administered FFP or perhaps FP24. Another application of FFP is for our so-called heparin resistant patients. If the patient's ACT is still low after 800 to 1,000 units per kilogram of heparin, then the patient is likely AT3 deficient. FFP has a therapeutic concentration of antithrombin and may be administered to help anticoagulate these patients. In another scenario, if the fibrinogen concentration is low and the K and the alpha angles on the TAG are low, then cryoprecipitate may be indicated. Lastly, if the platelet count is low and the platelet function analysis or the MA off the TAG suggests diminished platelet activity, then a platelet product may be indicated. And just for the sake of completeness, there are some pharmacologic approaches to our patients' bleeding problems. I've listed a few of them here. These are the more popular ones, though this is not a complete list. Clearly, the easy solution to residual or rebound heparin is to administer the proper dose of protamine. AT3 concentrate is a quick and convenient solution for the AT3 deficient patient and can often be employed much sooner than FFP. There's also a recombinant factor 7 product which is approved for hemophilia patients, but it has received a fair amount of attention in our field for off-label use in patients whose coagulopathy is unresponsive to conventional treatment. In our field, we commonly use antifibrinolytics, particularly Amicar or tranexamic acid. These agents help prevent breakdown of clot by blocking the conversion of plasminogen to plasmin. So that briefly summarizes our therapeutic treatments for patients with bleeding, including the blood products and the pharmacology that we have in our toolbox. So now let's try and wrap this all up. We should be just about ready to take a look at the patient scenarios that are posted online and will be discussed at the conference. Whenever we have a patient with a coagulation problem, we have to employ a systematic process for differentiating between all the possible causes and focus in on the proper therapy for the patient. We must weigh the evidence in favor or against the patient having residual heparin on board, dysfunctional platelets, a factor deficiency, or perhaps early clot lysis. Though not discussed here, somewhere in that differential diagnosis is the consideration that the problem may on some occasions be more surgical than biochemical. The straightforward process for diagnosing your patient's bleeding condition probably takes these kinds of steps. You have to rule out residual heparin, you have to make sure the patient is warm, and then you'll run a battery of tests. I've included in this presentation a table which identifies the laboratory and point-of-care tests that we've talked about. It also identifies the coagulation variables that the tests will monitor and makes a suggestion for the blood product that may be chosen to treat abnormalities of the results of these tests. Pay special attention to the footnotes at the bottom of this table. You can pause the video now to study this, or you can download this table from the online classroom. So in conclusion, coagulation may be complex, but treating bleeding in the heart room doesn't have to be. What you should do now is take the online quiz. You have to take that quiz to get your extra American board point. While you're in there, review the posted scenarios to prepare for our meeting in Baltimore. These are the same scenarios we'll discuss in the group, and we'll use an audience response system and hopefully have a lot of discussion and share people's experience around these issues. So please bring your comments and your experiences to the lecture. This won't be a lecture so much as it will be a discussion that Jeff and I will facilitate. Thank you for participating in this screencast. This is a new technology that we're considering employing at a much larger scale within our educational system, so your feedback would be very appreciated. Have a great day. Look forward to seeing you at the conference.